Top Med Talk.
Nick Harrison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
So our first speaker today is Professor Toby Richards. He is an academic professor of surgery, and he was, until 10 days ago, at the University College London, and he's just moved to University of Western Australia. He's a practicing vascular surgeon. He's a strong interest in clinical trials and patient blood management. Our next speaker is Dr. Kate Burbury. She's a consultant haematologist, stream lead for myeloproliferative disorders, chronic myeloid leukemia, and lead clinician for hemostasis, thrombosis, and perioperative optimisation, including prehabilitation for all major cancer surgery at VCCC. Our next speaker is Associate Professor Bruce Waxman. He is a retired colorectal surgeon with 30 years of experience at Monash Health, and he's also an administrator, so we're hoping that David Story's not here. Thanks very much. Oh, we've got... Oh, my goodness. Good. We've got about 30 questions. Bit of a worry. Might start with this first question for both Toby and Kate, which is about the Poise Trial. So this is actually from Bobby Jean, and she's actually said, look, the Poise Trial was fundamentally flawed. Only 23% of patients had coronary artery disease and less than 5% had stents. Most of the patients were taking aspirin were doing so for primary prophylaxis, so therefore had a low perioperative cardiovascular risk. It's not surprising that all they showed were bleeding complications rather than vascular events, and this is the only study showing that. So is the Poise trial in fact valid? I've had trouble trying to change things in my department regarding aspirin, so I'd be interested to see what you say.
I think it's the fundamental question about how do you take apart a randomised controlled trial. Having conducted a randomised controlled trial, I've stopped criticising any other randomised controlled trial ever. I'm sure when mine comes out, which I designed 10 years ago, it'll be pulled apart. And my only comment is always criticise the protocol, but never criticise the results. Data are data. That's what we've got to work with. And the Poise study has been validated by the Atticus study, and it shows that aspirin causes bleeding. I think if you've got a patient who's very high risk, who perhaps may have had a stroke and is on aspirin for the treatment of that, then I would probably continue in that group. We've got a long way to go to readdress these myths. Look at the trial that's just come out of Monash saying that we don't need aspirin in the over 80s. I think we need to address our polypharmacy. So I go with what the Poise trial says.
Okay.
Perhaps just to add to that, I think probably what we're doing too is moving further away from just data-driven, evidence-based medicine, which is what you're alluding to, and personalising it. And the first question I always ask is, does it need to be stopped? And that's, as a haematologist, I'm happy with any antithrombotic, but at the end of the day, the operator needs to be comfortable with that as well. So probably what needs to come into the dialogue is not a one-size-fits-all in your department, but at least encouraging people to ask the question in the perioperative setting when you're preparing the patient and making them fit for surgery is, does it need to be stopped from a bleeding risk? And what would be the repercussions for the patient if they had a thrombotic event? And I think if you take that approach in terms of principles, that'll empower you going forward.
Thank you. I'm going to switch to Bruce. A question about would RACS consider making operating with respect available to ANSCA, to the College of Anaesthesia? Would the College of Surgeons make operating with respect available to other colleges?
Oh, okay. Yeah, a good question. I think it's a matter of ANSCA and RACS getting together and agreeing to have a memorandum of understanding that we all should operate with respect. And indeed, the ANSCA president is on the RACS Council, and I'm sure it would be an easy way of communicating that message at the level of council. So it's a top-down approach.
Thank you. Back onto sort of haematological matters. Isn't it time to treat men and women equally when it comes to haemoglobin level? Women do not have less haemoglobin, they are chronically anemic.
I'm going to ask the haematologist.
Yeah. Well, actually, it was really refreshing to see you show that data, because you've got to remember where normal ranges come from. And they're very historical, and that's what I think's come out of the ferritin data, out of readdressing normal ranges. And so you go to your lab and you go, that's the normal range. So we have this sort of dogma that females have this range, males have that. And that's because they've gone to a population base, maybe women between the age of 18 and 30 who'll give blood to the lab, or maybe to the blood donors, and developed a normal range. And I think what was really nice is turning that on its head and actually just showing that anaemia is bad for everybody. Because if you start with a low blood count and then you go to an operating theatre, it's only going to get worse, not better, no matter how meticulous you are. So I think that was what was refreshing about showing that.
So your optimal haemoglobin, so Olympic athletes run at about 140, 141. We've shown that's the bottom of the UK U-shaped curve for haemoglobin before you start becoming polycythemic. And data that we've looked at separately, we took women with a haemoglobin of 12, ferritin less than 15, which is remarkably common because iron deficiency is the disease. And we gave them a bag of iron. And we CPET'd them before and after, and we showed an average of 5.4% improvement in VO2 max in 2 weeks. So if you take a woman and you regard them as normal at 12, they'll improve if you treat them properly.
Thank you. Bruce, a question about if you're a clinician, do you have advice about dealing with management when you're trying to create change in a hospital?
The two approaches to this are, number one, empowering. That is, empowering the staff to see that change is important. And the second is to develop some principles around change and maybe make the staff understand the 6 different steps in the Cotter change management approach. So they have to be able to embrace the change. And I think with those 2 principles, one should be able to be successful in undertaking that. You have to be able to carry the staff with you. It can't necessarily be, I said before, top down. It really should be bottom up. And if you've got engagement with your staff, you're halfway there.
Thank you. Prof. Richards, what's your practice re cell salvage in septic patients, for example, an infected AAA graft?
Well, I don't lose any blood, so it's not a problem. Look, I do that technique of the bowl of 1,000 mils of saline with 5 or 10,000 of heparin in it and do swab washing. If you got frank pus, I don't do it. But apart from that, I use it for pretty much everything. So if I was taking out a lower limb infected wound, the bleeding normally comes afterwards. It's the ooze that's the problem. It's not the cut and the blood loss. It's the fact that I've flayed open the leg and it's sitting open for 3 hours, gently dripping away. And then the patient comes cold, and you know the story. But yeah, I use cell salvage in that setting. I don't think it's a problem. Any comments about cell salvage in an infection?
I mean, and to take that extension further, we did a few studies, and there's not a lot of data out there looking at cell salvage and what it actually does to your hemostatic activation. And that's my only concern, and perhaps being an anti-clotter puts me in that space. And so you definitely see activation of hemostasis in the blood that's collected, not surprisingly. You've got active factors and platelets in it. So my only caution is, like you say, in someone that's got frank activation of their body cytokines. And I'm a bit cautious in orthopaedic surgery because at the surgical site, what comes out with that blood as well. So again, I wouldn't go with a one-size-fits-all. I think in a cancer hospital we have a healthy caution of using it, not because we think that the cancer is going to be come back, but perhaps more the cytokine release in the bloodstream that's being captured at the surgical site.
It's always a hot debate. As a cancer surgeon, did you use cell salvage if you had a difficult case, or was that a no-no?
Well, I have to say that I didn't ever use a cell saver. Not that I didn't have bleeding, But I think the other, I suppose the concern about bowel surgery and self-saver is the potential of contamination of the blood with the bowel content or the bacteria. So I hope that's a sensible answer to your question.
There's just so many questions here. Probably only got time for a couple more. Should we give IV therapeutic load of iron on the day before surgery or during surgery?
There are two questions on iron in that setting. One is, what is the diagnosis of iron deficiency and how do you make that diagnosis in the preoperative patient? Ferritin is not that accurate. You could use transferrin saturations. There's a Thomas plot. We don't know the answer. The second is, does it make any difference? Intravenous iron is still an intervention. It's a safe intervention. You can use it, and you in Australia use more intravenous iron than any other country in the world. You're the leaders. But if you're just swapping one intervention for another, then what's the point? And I think as a trialist, we need to prove that the intervention of intravenous iron is better than an intervention of a bag of blood. I think we can probably equilibrate the two at the moment, that if you give a bag of intravenous iron, you probably save a bag of blood. But you're just swapping one intervention for another. We now got to work out whether or not that's the right thing to do. Because it's actually harder getting someone into hospital a few days before and giving them a bag of iron.
And the only other thing to add to that, I suppose, which you've alluded to, Toby, is what is the purpose of giving the iron? And I think you covered it in your talk, there's more than one important role for iron. One is restoration of oxygen carrying capacity in the red cells, and we know by giving iron, that doesn't get restored into the red cells for about 4 to 6 weeks. So you need that time frame to restore that oxygen carrying capacity to its full capacity. But then the other benefits of iron that we see in terms of enzymatic reactions. And again, I suppose my rationale for doing it earlier than on the day of surgery is, are you going to get any benefit from giving it in the intraoperative period when the purpose of giving iron was to achieve all of that? So obviously giving the opportunity to get the benefit from the iron is paramount. I know there are concerns about giving iron in an operative state from a cytokine release. I'm not sure if that will be real, and we'll wait that. I'm more angle it from, you want the benefit of the iron, give it a day plus before the surgery.
There's an easy answer to this, though. We'll be doing that trial next year, so if you have that question, just enrol the patient in the trial. It makes my life a lot easier standing up here.
There's an enormous amount of interest out there, so if you're still interested, I'll get you made a pop-up later, say hello to our speakers, but also use Show Gizmo to talk to them. So I'd like to put your hands together to thank our speakers.
Mick Majerison here. On August the 11th, 12th and 13th, the American Association of Nurse Anaesthetists will be holding their annual Congress. Top Med Talk will be coming to you with live updates from the meeting as it happens. We'll be interviewing thought leaders, academics and prominent practitioners for 3 days of discussion and debate. The opioid crisis, enhanced recovery, innovations in anaesthesia and much, much more. Guests will include the president of the AA&A, Gary Bridges, Lynn Reid and Lorraine Jordan, to name but a few. To get ahead of the curve, why not listen to some of last year's podcasts from the AA&A? Simply go to topmedtalk.com and type into the search engine AA&A. Pop that in and you will find our output from last year. In the meantime, of course, if you want to find out more, the American Association of Nurse Anaesthetists are holding their annual Congress August the 11th through till the 13th. Go to topmedtalk.com for more details, and while you're there, make sure you subscribe to Top Med Talk, and of course, that you've joined us on social media. That's topmedtalk.com.